Alright, you're probably wondering, what the heck is this? Looks pretty well meaningless and a huge waste of time, right? Well, it reminds me of our current clinical care standards for low back pain. Yeah, let's have a look at them. This is their publication from the Clinical Care Standard Back Pain Committee. I'll show you who they are later, but this is the pyramid of priority: meaningless and unhelpful. Initial clinical and psychosocial assessment. So for a condition that is a biomechanical problem, for 99% of people with mechanical back pain are expecting that physical therapists start off with a psychosocial assessment. And then we talk about patient education, and all that's very good, but we don't really describe in our guidelines what sort of education, and how do we advise a self-management program for these patients who are often disabled with pain. Physical therapy plus or minus, and or psychological interventions as second line as well, and then some pain medications to throw in for symptom control. Then we review the progress, which of course is going to be bad, and then we reassess and adjust the initial management. So we go back and do some more psychology. If the patients are continuing to deteriorate, we refer, and we consider a multidisciplinary approach. So now we might actually even get in a psychologist to actually do something, because that's what they expect is going to fix up our back pain, is psychology. Because back pain, it couldn't possibly be a mechanical problem, could it? Let's ignore the biomechanics of joint movement. And then, if it's still bad, maybe then we'll get some imaging, and then we'll send them to the specialists, okay, the spinal surgeon or the neurosurgeon. And guess what I'm going to say to them when they come to see me with their structurally compromised facet joints and discovertebral joints and sacroiliac joints from a complete and utter ignorance of biomechanical movement skills. I'm going to say that there is no possible way that you're going to be able to salvage the instability that's associated with your spine now. And the only way that we're going to be able to reacquire that stability is with a spinal fusion or a dangerous artificial disc replacement surgery. And of course, it's entirely avoidable if we understand that back pain is a movement dysfunction disorder, and we deliver movement therapy at a very early stage. We can prevent millions of people from suffering from chronic pain and disability, and prevent thousands of people requiring spinal surgery or spinal stabilisation surgery. Let's have a look at the Australian Bureau of Statistics Burden of Disease study. There you go. On the left-hand side, you can see the columns of disease burden hierarchy. Up the top in orange is coronary artery disease or coronary ischemic heart disease. Second, in 2003, in yellow, back pain. Now have a look on the right-hand side. You'll see that coronary heart disease is still number 1, back pain is still number 2. But look, at least the cardiologists have made some gains. They've made some improvement in the burden of disease. It's come down since over the last 15 years. Look at the back pain ranking. It's still in second place, and it's increased. So the rehabilitation methodologies over the last 15 years have done nothing but result in a deterioration in lumbar spine health. That is just unacceptable. Let's have a look at our guidelines: College of Functional Movement Clinicians, Clinical Care Standard, Early Education and Functional Intervention, consisting of recognition of red flags and effective symptom control, in conjunction with controlling the functional cause of pain. How do we do that? with specific and distinctive movement therapy, upskilling movement proficiency. If patients are not trending how we would expect, i.e. a reduction in pain, reduction in disability, and increase in functional capacity, then we do need to consider imaging and specialist referral for a consideration of a structural intervention such as surgery. And finally, we need to get the message out to the broader community about lumbopelvic biomechanics in activities of daily living, be they trivial or physically demanding. That is going to put spinal surgeons out of business, and it's going to keep functional movement clinicians very, very busy. So the demand for functional movement therapy will steadily increase as the burden of unresolved movement dysfunction and resulting increase in chronic back pain and disability and poor functional capacity relentlessly progresses, as the trend has been for the last 15 years. Our expanding collaboration and clinical outcomes will see it become a first-line treatment. These organisations and individuals that are currently involved in establishing the guidelines have zero concept of functional movement proficiency and hence develop meaningless, unhelpful guidelines that will not improve the increasing epidemic of back pain. So in the bottom right hand corner, the working group, I can promise you that those guys have no idea how to lift, they have no calluses on their hands, they have no idea about biomechanical movement proficiency for lifting, and we do, so we have to step up and start to contribute to meaningful guidelines that are going to make a difference. So back to the video. Let's bring this sort of nonsense to an end right now.